Thank you. Welcome to all of our guests. Thank you, Cathaoirleach. I have a couple of questions first, maybe for you, Mr. McCartney, and if it's possible, if you could answer the questions first. I appreciate others have different fields of expertise, but if everybody answers the first question or questions that are put, the 10 minutes will be up, and I want to get to where we go from here and what the HSE needs to do, which I think is the most important part of this meeting from my perspective. But just to get a bit more sense of what the issues are. So in your opening statement, you say there is an extensive body of international research showing the protective role of vitamin D. You then talk about geographic studies which have shown that COVID-19 incidence and mortality are higher in countries far from the equator and in countries with confirmed low vitamin D status. You go on to say that in May 2020 there was data showing a direct relationship between low vitamin D and increased risk of SARS-CoV-2 infection, severe disease and death emerged. Can you give us a bit more information as to where that data is coming from?
Yeah, there are quite large studies coming from the USA and Israel in particular in relation to risk of SARS-CoV-2 infection. There's a study from Chicago, for example, nearly 500 patients, 71 of whom tested positive for COVID-19. And that study revealed that if you were vitamin D deficient, you were 77% more likely to be SARS-CoV-2 positive. There's a larger study, again from the US, 192,000 people.
No, I know the countries they come from, but I'm talking about what's the source? Are they academic studies? Are they coming from R&D facilities? Are they coming from universities? So what's the background to the studies?
Yeah, they're academic studies really. So these are medical academics. For example, the lead researcher on the study that I mentioned there, that very large US study is Michael Hollick. He's attached to Boston University and he's a medic. The other study by Meltzer and colleagues in Chicago, same, it's a clinical study, university academics with medical sort of facilities. That's where the studies are conducted.
Okay, and you also say, and this is just more for clarity, because I'm really conscious that people are very frustrated at the moment with the fact that we're still in this situation almost a year on from COVID. Obviously, it's a difficult time for everybody. So when claims are made that we can reduce mortality, obviously, and I'm not saying that those claims are wrong, but obviously they have to be peer-reviewed, they have to be evidence-based. So when you say that there is also an unpublished public health initiative in Spain which has demonstrated a remarkable reduction in COVID-19 mortality since vitamin D supplementation of vulnerable older adults, that is unpublished.
That's right.
And again, what's the source of that study?
The public health authorities really, I suppose, took evidence from a smaller study in Cordoba, Spain, which is published. Cordoba, as you know, is in Andalusia, and it's a small study of 76 COVID-19 patients. So those were divided in a 2-to-1 ratio, such that 50 of those 76 patients coming into hospital received vitamin D in an activated form, a reasonably high dose, quite early in their admission, day 1, day 3 and day 7. And the other 26 received standard care, but no vitamin D. And they followed those patients over the course of their admission. Of the 50 who received vitamin D, there was just one person who ended up in ICU, so 2%. Of the 26 who didn't receive vitamin D, 13 of them ended up in ICU, and unfortunately 2 of them died. So there was a huge difference there, as you can see, in terms of ICU admission, that translated to a 30 to 35-fold difference statistically in your likelihood of ending up in ICU. The public health.
Can I just maybe put a follow-on question?
Yes.
Because you say in your opening statement that you believe that there is an extremely low risk, readily implemented, cheap and potentially highly effective intervention to mitigate this public health crisis.
Yes.
So I'm assuming, and just for the purposes of clarity, I'm assuming that you would argue that would supplement all the other measures. They're not substitutes for all the other public health measures for the vaccine rollout and so on. So this would be an addition, just for clarity purposes, because again, when people are at the end of their tether and they're, in a really difficult space, we want every and any option on the table, and I certainly would. But what you're arguing is this would be an addition. Would that be a fair?
Yeah, that's a good point, Deputy Cullinane. We want to be absolutely clear here that we are recommending vitamin D supplementation in addition to these other health messages in relation to social distancing, and also in relation to vaccine. It's an additional intervention that may yield benefit.
Very good. I want to get now to recommendations, which I think is the important part. So again, you say in your opening statement, political decisions and recommendations which flow from today's meeting must be the right ones, and the policy actions into which they translate must be delivered swiftly and decisively to alter the trajectory of this pandemic and to save lives. Sure. I don't see many recommendations in your opening statement, so I'm assuming you wanted to flesh those out in the context of this conversation. So when you say that you want to see action and you want to see interventions and you want to see solutions, if I can just give you the floor for the remainder time that I have, maybe if you could spell out, if you were talking directly to the HSE, to the Minister for Health, what immediate courses of action do you think need to be taken by our public health specialists, by the HSE and by the Minister in these areas? So what policy actions are you recommending?
Well, the first and most important of those, Professor Kenny has already mentioned. We think that a recommendation, an explicit guideline for people, adults in the Irish population, to supplement at 20 to 25 micrograms per day or 800 to 1,000 units per day is absolutely essential. We also feel that higher supplementation may be required under medical supervision in at-risk groups. So those would include people from BAME communities, people who are overweight or obese, which is 60% of our adult population, and also older people or people in nursing homes in particular, who have notably lower vitamin D levels than the rest of the population. The other questions that may arise here is whether we give vitamin D free, as they have done in the UK, to specific at-risk groups. So do you supplement, for example, people in nursing homes or in prisons or in other long-term care institutions where their vitamin D levels are likely to be compromised? We think that there are a number of discrete populations that you could supplement. For example, people in nursing homes. We know that half of the mortality that's been observed in Ireland in relation to this COVID-19 pandemic has occurred in these settings. So we think that that's a no-brainer.
What about those in public hospitals, Mr. McCartney? What guidelines are in place for patients in hospitals, which would also, I would imagine, be an obvious place to start?
Yeah, absolutely. The question about whether we supplement vitamin D to hospital patients is absolutely valid. I think that would be a very useful intervention. And I mean, that they are another group, certainly, where there are data to suggest that they have lower vitamin D levels than the rest of the population. So certainly for people coming into hospital with COVID-19, you would imagine that might be a beneficial thing if they can convert the vitamin D into its active form quickly enough. There are other groups here that are susceptible. So for example, people that are attending for COVID-19 testing, by definition, there's going to be a proportion of those that are COVID-19 positive and in the early stages of the disease. So we think it would be very useful to supplement them, to provide them with free vitamin D when they arrive at the testing centre. So those groups, I mean, there are others. We don't know what the vitamin D status is, for example, of people that are in meat processing plants. We might speculate that their vitamin D levels are low, but it's certainly a high-risk environment. So they might be another group that we would look at. So it's these sort of very susceptible groups. The nursing homes, though, really, really important that they implement this advice. And at sufficient levels, as I say, 20 to 25 micrograms per day or 800 to 1,000 units might be sufficient for most adults. But in nursing homes, they may require higher doses than that to reach the minimum thresholds for adequacy under medical supervision.
Walsh was looking to come in there. Professor Walsh, do you want to come in?
Yeah, thank you ever so much. No, I think that the Department of Health recently, and this is in answer, Deputy Cullinane, to your question, the Department of Health recently have come out and mentioned about 600, right? And you're saying, well, we're saying 800 to 1,000. So we don't seem to be that much different. Well, we're not actually. And the other reason that we're not, if you want to, but I think it's important, that but our emphasis is slightly different. 30 nanomoles per litre is a blood level for deficiency, right? 30 nanomoles per litre. And 50 nanomoles per litre is what we normally take as sufficient. And that 50 could, at 30, you still have a level of secondary hypoparathyroidism. You still have the body struggling to bring it up. At 50, for all our bone health, and we have 7,000 coming to our clinic every year, 10 every year, we aim to get everyone up to about 50 nanomoles or even slightly above it, because as you get older, we like people to be around 60 to 70 because there's slight reduction in falls as well. Therefore, by going, they recommend 600 to bring you up to 30. So what we're saying is take 800 to 1,000 units. And when we say 800 units, they also, and you heard Dr. McCartney saying about 800, you'll see sometimes 20 micrograms, and for 1,000, you'll see 25 micrograms. So they're written in two things. But you should think of units because they're very straightforward, I think, because that's the way clinicians think. Nutritionists often think in micrograms, but they're all both written in the bottles. So 800 to 1,000 units a day is simple. And as Professor Kenny says, there's good evidence that shows that people actually go up to 4,000 a day. We don't come near that. We don't come near that. I just tell my patients to take, now having said that, I put my hands up and I say I take 2,000 today. I don't apologize for it. Is that okay? And we know that things like fortified milk, I mean, if you take a litre of half litre of super milk, you get 400 units in a day, and cereals as well is fortified. But other than those two, they're like fortified milk and, for instance, fortified cereals, there's very little food available that has vitamin D. Farmed salmon get it because they go out and eat the plankton. Oh, sorry, wild salmon get it because they go out and eat plankton. But farmed salmon don't. they don't get the opportunity. So they have only a quarter the amount of vitamin D, do you understand? And that's the other thing that they mention as having vitamin D. So therefore, the food sources are quite limited, and that's why we get deficient. And young people, let's say, working in factories, young people working in hospitals, we had a higher level of deficiency in our 36,500 in younger people than we had in a lot of the people as you get older, paradoxically. So people who are indoors, whether at work or in environments like not only just nursing homes, but when you can think of the fact number of people have been indoors in recent times, their level of deficiency potentially for those. And our study, which we published only just recently, was over a 5-year period, and there was totally consistency every single year. Goes up in summer, but still a level of insufficiency or deficiency of 30% and 70% in winter. So it's a real epidemic. And we've seen in the high incidence in the BAME communities, who are the highest level of deficiency and insufficiency, how they have been so badly struck down with COVID. And they're the kind of things that worry us. And that's why we're here today. That we're saying this is a simple solution. It's just giving you a bit of sunshine in winter when we don't have any. And a simple day. And it's totally safe, by the way. We had, of our 36,500 people, we had only 21 patients with a level over 250, and all of them had a normal calcium. There was no one had any side effects. So that's the other thing as regards safety. And we had, so you don't get, very rare to get high levels unless people are taking something like 5,000, 6,000, 7,000 a day. It's rare to come across that animal, to be honest with you. People don't do that. They're sensible. And the farmers don't belong wrapping their knuckles.
Thank you, Professor Walsh. David, you've come to an end of your time.
Just one final comment in relation to Deputy Cullinane.
Go ahead.
The other group that really could benefit from vitamin D supplementation are our frontline healthcare workers. And the reason for that, there are a number of reasons for that. Firstly, because there are data to show that they have lower levels than the rest of the population. Secondly, because they will comply with those recommendations, being healthcare workers, they will see the value of doing that. So thirdly, they obviously have a very high occupational risk in terms of their contact with people that have COVID-19 infection. So for all of those reasons, we would view frontline healthcare professionals as a particularly useful group to supplement with free vitamin D as well.